Among the things that we have learned is how the EMRs are used are going to affect the success of personal health records and health information exchange in general. All three of these clinics, as I said, are using the same electronic medical record system. In fact, two of them are on our application service provider application, so we have some control over their EMRs. The third has implemented theirs independently. And we have learned that there are significant differences, certainly between clinics, but also within clinics in how physicians use and enter information into those EMRs. And how that data is captured has actually influenced the interface, influenced the health information exchange. Just as a very basic example, after we brought the system live, we found that there were some HL7 messages that weren't getting across. They were getting stopped in transit from our system over to Google Health. Well, upon investigation, we learned that it was because some of the physicians, when they typed in the medication information, were entering what is essentially a pipe, entering the character as a delineator. For their own personal reason, for whatever reason it was, and then when it went through the HL7 interface engine, it interpreted that as a delineator, and it killed the message transmission. Just a very simple thing, but it took a fair amount of investigation to find out why some messages were dying and others were not. Now, you would think that medications and allergies would be fairly standardized, and that's part of the reason why we started with those limited data sets, sort of the easiest case scenario. But we also found things like how the patient is displayed to the patient, how the data is displayed to the patient are affected by the way the data is entered, of course. Google right now has it set up so that anything that comes across goes directly into and is displayed as transmitted into the Google Health account. Well, some of the physicians found that concept rather alarming because they weren't sure that they wanted the patient to see exactly what they had typed in to the medical record. And one example they gave, again, seemed very basic, medications, but apparently some of the physicians free text in things like, this patient may be a drug user, and so they didn't want that showing up in the patient's Google Health record. So there were a lot of things that we found complexities in what would on the surface be a very simple process. We also found, in thinking about it, that we were just working with medications and allergies, and if you start moving beyond that to labs or diagnoses or procedures, it's going to get even more complex. So based on our experiences, we just have a few recommendations I'm just going to walk through very quickly. We've learned that it's really important that the EMRs support how clinical care is actually delivered in the different practice settings. And of course, everybody is aware of the need for workflow changes as an EMR is brought into play. But these processes have to be so flexible and have to allow the different users and different practices to use the system differently. And there's a lot involved with the human-computer interaction, and the human side is definitely the complexity in this equation. I think we're all aware that just about any end user has the ability to mess up the best designed application. And so it's important that the end user, how the end user is going to interact with it, how the screens lay out, navigation and so forth, will make it much easier. Because the harder it is for the end user, the more likely they are to skip over or to mistype or to just not give you complete information. With that in mind, the EMR design can actually affect data quality, and this is something we're seeing over and over again. So if they're entering abbreviations, do they all use the same abbreviations? Probably not. The number of clicks, just thinking that you're going to get a physician or a nurse or a medical assistant to go through 20 clicks to do something is probably a little naive. You have to make it as easy as possible so that they aren't trying to skip through and missing steps and not capturing the information. If it takes too long to get from one screen to another, they're going to skip steps. They're under time pressures, they're trying to work as efficiently as possible, and the EMR should be facilitating that, not getting in the way. On the other hand, thinking back to the fulcrum I showed a few moments ago, standardization is certainly needed. If you're going to be sharing data, I mean, Dr. Davidson brought up some examples of the importance of what they were having to do around identification and some of the issues in establishing a large-scale HIE. So that standardization, we all know, has to happen, but it really needs to happen as much as possible in the background. And thinking about, I put on here the Amazon as some of the other current models for customized interfaces that still have standardized back ends, but when you go in and you buy what you want to buy on Amazon, they're customizing all kinds of things for based on your history. We need to be building that kind of intelligence into our electronic medical record systems. Because again, if we try to force compliance, the end users will find a way to work around it. And that's going to affect the data quality, which, as I said at the beginning, is really going to affect the entire chain for clinical care. So I know that we're going to be going on to the next speaker. So we'll hold questions. And
any clarifying questions from the group? Okay, well, then we'll move on with...
Just one.
Yes.
Your EMR penetration is at what?
It's about 66%.
Now we'll move on to Holt Anderson from NCHICA.
Thank you, Art and Jack. I want to focus on instilling confidence in the users and the consumers of this. And I'm looking at different groups who look at this process differently. Consumers or patients or members or clients, however you characterize them, are one group. Care providers are a different one. And then their organizations are yet another group with a different perspective on the whole issue of accuracy and authenticity, integrity. And then the business associates and vendors play a major role here. From a consumer perspective, of course, they're interested in the quality of care and timely care, and they're beginning to get it, that their copays are affected by the timeliness and quality of care and duplicate tests and so forth. And they want accountability. Their privacy and security is at the forefront, and now that the NHIN is beginning to take into consideration consumer preferences and being able to express those preferences in the way we handle and exchange their information is crucial. If you're a provider, they're really dubious of information they get from sources other than from their own organization. So the provenance that we're talking about is extremely important. There is a certain expectation the information you're going to get from other sources is or is not complete. So how do we give them confidence in the completeness of that? Being flooded with information is not necessarily helpful. Giving it to them in an organized, concise fashion that they can digest and quickly take care of that patient's awfully important. And then who's accountable for this information? If I'm using information to make clinical decisions, how do I know that I'm doing the right thing? And ultimately, each provider who's getting information from other sources is responsible for making that final decision, that final clinical action. So are they verifying that information with a patient? If you're a organization, then you have business considerations for this exchange of information and what are the rules for appropriate use. Boy, this whole new world of health information exchange is giving me as a manager of a provider organization new concerns. What about the exposure that we have for sending information to other places or receiving information and acting on it in an inappropriate manner? What about breach that's caused by this exchange in this new environment? The breach may happen at another organization. How does that affect me? This is a more complex environment that we now have to manage, and I've got to transition from legacy systems. So am I going to be going full bore into this new world of health information exchange, or am I going to be cautious and step into this slowly? If you're a business associate, you're going to look at it somewhat differently in that what is my liability as a business associate in this new exchange? Am I going to be caught up in a breach? Am I going to have to get my legal folks involved more than I have before? What is my exposure? If we do have a breach, there's 60 days for the covered entity to report. Well, if I'm a business associate, maybe I can wait 59 days and then report there's been a breach. A lot of issues to be resolved there. And I think some good news, and we've been working with some of our vendor advisory council members who are members of EHRA, the Electronic Health Records Association, and they've actually convened and are discussing developing and monitoring a notification system. So they're sort of looking at this issue and seeing, as a vendor community, what do we need to be doing to make sure that the community is safe. From a policy standpoint, a lot is emerging through the NHIN. The Data Use and Reciprocal Support Agreement has now been signed by the VA and others. The new ARA additions to HIPAA. We need increasing enforcement to give confidence to everyone that the system is working and enforceable. That we're getting new technology requirements through the NHIN, the certification and the validation of an entity that wishes to join this exchange network, and being able to validate that they're not going to be a weak link in the chain that exposes information. And so, along with those requirements for joining, which will be memorialized in the DRSA, the Data Use and Reciprocal Support Agreement, will be all of these requirements for coming on board as a participant in the NHIN. And now that we have the DRSA coming to light and other related documents around policies and procedures and operations with entities who are participating in the NHIN, we think it's going to be very helpful in instilling this degree of confidence. The DRSA itself has been developed over a period of about 2 years related to the governance of the NHIN, and has recently been signed this month by a number of leading entities in the country, and so it is in force and ready to go. The document itself is a policy foundation for building trust and confidence in the system. It is a multi-party agreement. There'll be a joinder agreement for a new organization that wishes to participate. It sets a foundation for expectations and responsibilities and behavior within this NHIN network of networks, frameworks. And it presupposes that each of these entities has a trust framework within its own community, that it is acting as a proxy for other organizations that are using the Health Information Exchange as an entry point to communicate with others. Some of the key components we've already talked about. I want to focus on the permitted purposes. And you will notice within this list, treatment, payment, operations, public health activities, the quality reporting that will be required for meaningful use, and other disclosures that are based on authorization from an individual, but not explicitly research. Research was too difficult at this point in time to encompass within this. But if you have the authorizations, fine, go ahead and do that.